So multi-level MIS-TLIFs challenges, tips, tricks to overcome them, and the outcomes. This was my first multi-level that I did. Two-level in a recently. So he had had a bypass surgery about 4 months prior to this. This is his 15-year post-op X-ray. That is, he was operated in 2009. He continues to walk. So this X-ray, if you see, is actually everything that can go wrong with the sagittal balance, non-distraction of the disc space, but still it worked for him, and it's working for him for the past now 16 and a half years. Well, every surgery is going to have a learning curve. It's better to have started and finished with it than to have just thought about it and run away from it. Always, obviously, start with a single level, become comfortable, collaborate with other surgeons, invest in good equipment. You cannot win an F1 race with a taxi that runs on any of our roads. You have to have the top end equipment for that. Invest in good OT staff. They will keep you sane while you're operating, and always have a plan B ready. Start with an L4-5, L5-S1 level. If you're a right-handed surgeon, try to find a case that would be allowing you to do access from the left side. So because the same entry point will get you across to both the levels. Well, when the degeneration is nearly similar, as you can see, this is a grade 2, probably a 3 in the grade in L4-5 case. In such cases, try to do the lower level of the curve first, because if you do the L5-S1 first and then move to the L4-5, a lot of blood is going to seep into your field through the connection, and you'll find it difficult to operate. However, so do the lowest disc first, because if you do the lowest disc first, then by the time the blood wells up and moves into your field, you still have some bloodless time and you can work on it. However, if there is a big disparity in the deformity, here you can see the L5-S1 is much worse compared to the L4-5, which is just degenerated. In such cases, as you can see in the collage here, we would do the L5-S1 first, get it reduced. It makes access to 4-5 easier, then of course put in percutaneous screws and reduce them. This is how it should look on the skin. If you go for cosmesis, this is probably more uglier than a single midline incision, but it is much better for the muscles and the soft tissues inside. So this is the thing. But other thing that to remember, the only neurodeficit I ever had in my MS surgeries is where I didn't do the over-the-top decompression before. In a severely stenosed two-level deformity, there was a very arthritic facet on the other side. By the time we finished the disc space, the nerves were compressed and the patient woke up with a foot drop. She partially recovered, but still is very bitter about that. So a very steno segment and anything above a grade 2 listhesis, do over the top decompression before you do the discal work, so that there's some place for the dural sac to retract into. Use, apart from technology, a little bit of common sense. You can use your table to, if in an L5-S1 level is going to be at that angle, you can just give a head high to make it more perpendicular so that your neck doesn't have to ring while you're operating this. Mark your entry points on skin when you're taking long levels so that they are linearly placed. Other common problem is you do an L3-4, it's more at the L3-4-4-5 level. You have done L4-5, you're now going to the L3-4, and then you see that instead of 2.5-3 centimeter cut, you have a 5 centimeter cut, and your tube doesn't hold because it has no function. Simple thing to do is to take 2 vicryl stitches in the aponeurosis and the deep fascia, and that will give you the tension required for the tube to be held more securely. If you find that it's a big patient and the discs are away, don't try to use the arc, just make a new entry point and going. The idea is to do minimal muscle damage and not try to make your life difficult. In deformities, this is my personal experience. We haven't been able to analyze the data yet, but I always do my disc work first. There are a lot of surgeons who put in their wires and then get along to doing their disc work. I'm very scared, especially in osteoporotic patients, to have those wires hanging while I'm working and my hand can go and bang inside one of them coming out. So I do my disc work first. I do the worst level first. Either in the coronal sagittal plane, whichever is the worst level, do it first. Do not expect the screws to do the reduction. In an MIS surgery, the screw is going to come to the rod, unlike an open surgery where the rod is going to go to the screw. So if you're going to put too much pressure and expect it to hold, the deformity is going to pull out and you will have a problem. Have a low threshold to convert to open, because end point is going to be a good result, not something just to prove a point that I did an MIS for a long segment. And I'll show you the slide for the last point. Don't allow forward flexion and sporting activities till you see a decent union. This is one of the deformities we did for our anesthesia, cardiac anesthetist mother, 2-level deformity, 5 years since doing better. Always, I prefer to use reduction screws rather than screws that are mounted on candles, because reduction screws have a better gentler, you can gradually reduce them and have a better hold, and they don't come off like the previous older candles used to come off. You have to remember these are hollow screws. They are weaker than conventional screws which are solid and have a higher chance of breakage. So too much pressure on them should not be done, especially at the base of the construct. When you put in your screws, try to put them in a line. This is an old legacy system. This case is about 12, 13 years back. So if you have it in a line, you'll be able to put in your rod easier. If your screws aren't aligned, if one of the hole is on the side, you're never going to be able to negotiate that. Or if you do negotiate it, it's going to be plucked out as you reduce your rod. This is the newer reduction screws that we use for our cases now. In a case where this is the best case to do a long segment is where the L5 is sacralized. So this gives you a very long construct. You can do a T-lif at each place, and the lowest screw holds well. This is something we did about 8 years back. This is a case of osteopetrosis. A doctor who stays in this very city, that was the damages of, we broke 2 navigation needles, we broke this kerosene, and then these are the rest of the Jamshedis that was there. This guy went off after the surgery and came back directly after 6 months. We asked him, how are you doing? He said, oh, I started my golf within 6 weeks of my surgery. He plays a complete round of golf every single day since then. He's a retired company doctor, and this was his X-ray. So if you can, this is his CT and X-ray that we did now at 6 years. There is still no union happening here at the base. There is some fusion and stability that he has with osteophytes, but I'm waiting, hopefully that day never comes where it breaks and gives me grief. But remember to make your base solid. So this is what I borrowed from Amit. I would always put in now an S2 ilium screw. The only difference, thing you have to do differently is to put your S1 screw a little more, L5 screw a little more medially, so that it's straighter rather than a traditional S1 screw, so that your rods go in well. Use navigation for multi-levels, or use robotics, because it's just not worth the radiation for more than 2 levels to do it just with a C-arm. If you have to use a C-arm, there's a nice paper I'll be subsequently showing where a single shoot technique rather than a continuous shoot is better. Use good OT staff, because a good tech will show you it in a single shot what a bad tech will show you in 10 shots. So that reduces your radiation team up. Use multiple needles at multiple pedicle levels, so that in one shot you can see 4 or 5 pedicles that you have put in together. These are the millicil wet exposures that we all should be very worried about, and I'll just wind up 2 slides. Single shot fluoroscopy should be used. You should be careful in obese patients, because radiation in obese patients is much higher, and the radiation is also much higher to the surgeon's hand and to the gonads. So be careful on that. Bone quality, anything more than -2 should be ideally a contraindication for multi-level MIS T-lif, because the screws won't hold. Precondition your patients with anabolic agents. Cemented implants have some answer to it. And of course, coming to the evidence, there are a lot of papers which say that this works very well. And then there is this 2019 paper which says that as you go beyond 2 levels, there is a diminishing return. The truth probably lies in between, but whatever said and done, eventually it's all going to be MIS and very rarely open. So it's better to get onto the boat. Thank you.